I'm Don Hohman. I'm an orthopedic surgeon in Dallas, Texas. I do subspecialty work, I guess, in joint reconstruction. I did a joint replacement fellowship. Take care of a fair amount of trauma surgery and problematic cases that get referred to me by other surgeons. I recently took care of a 45-year-old lady who was referred to me from another surgeon. She was about 10 months out from an allograft ACL reconstruction. She had what appeared to be some signs and symptoms consistent with septic arthritis and what we suspected to be an infected allograft reconstruction. We underwent a laboratory workup, elevated inflammatory markers with ESR and CRP. We performed aspiration of the knee joint. The culture fluid grew staph epidermidis. So at that point we knew what we were looking at, management of an infected allograft ACL reconstruction with what appeared to be, based on the imaging, likely osteomyelitis in both the femur and the tibia. The first image I have there is the X-ray image on presentation. It's an AP of the knee, and some of the things that were concerning to me based on this imaging were, first thing you notice is the striking, what appears to be possibly bone loss and very likely osteomyelitis on the tibial side, and there's some findings that are consistent with osteomyelitis in the tibia based on just that X-ray alone. The femoral side of that didn't appear too concerning, but that's what prompted us to perform MRI. So on the MRI sequences that you can see, we have some signal change in the bone on both the femoral and tibial side. There's a large effusion, which you can see in the knee joint, and some of those signal changes are consistent with osteomyelitis in both the femur and the tibia around the anchors. So we opted for removal of the allograft, removal of the femoral and tibial anchors. We performed aggressive debridement of the osteomyelitis of both the femur and the tibia. These left relatively large defects, which were large to begin with, but they were larger once we were finished with what needed to be done to kind of get the infection under control. So at that point, we used the local antibiotic administration with vancomycin and tobramycin. We knew the sensitivities of our organism, and it was vancomycin sensitive. In order to manage the dead space, we used some of the STIMULAN beads in order to manage the large defect in the tibia. And actually the picture that I have included there is the arthroscopic photo of when I had the arthroscopic camera inside the knee joint looking down into the tibial defect. You can see that dead space, how well it was filled back with the beads to control the dead space as we treated locally with antibiotics. So we have successfully eradicated her infection. Her septic arthritis has been successfully treated. And on the X-ray that I have there in follow-up, she's nearly a year from this now, and you can see progressively over time how the tibia in particular has regrown and filled in that large defect that was created as we treated the osteomyelitis, as has the femur. She's gone on to have a successful result. She has a nearly normal functioning knee. Fortunately, she's not unstable due to her not having an ACL, but she has minimal pain because she does have some arthritis, but she's clearly not infected, and she's very pleased with the result.